Hello, and welcome to the Clinical Liver Diseases video series. CLD is an official digital learning publication of the ASLD. I'm Dr. Nikki Boschuetz, Transplant Hepatology Fellow at the University of Wisconsin-Madison and one of the authors of Alcohol Use Disorder, Recognition, Testing, and Initial Management Strategies. Alcohol use is common around the world, and its use is growing, especially in the United States. In a 2021 study, over 70% of people reported using alcohol, and over 11% of people met criteria for alcohol use disorder in the past year. Alcohol use is a common cause of liver disease, and based on OPTN SRTR data in 2021, alcohol-associated liver disease was the leading indication for liver transplant in adults, outpacing non-alcoholic steatohepatitis. As such, all patients in the hepatology clinic, and ideally initially in the primary care setting, should be assessed for alcohol use disorder. Alcohol use disorder is defined as the inability to stop or control alcohol use despite adverse consequences and is diagnosed based on DSM-5 criteria. Diagnosing alcohol use disorder can require an in-depth interview, but screening for alcohol use disorder can be done with various quick screening questionnaires, such as the Audit-C or the NIAAA single alcohol screening question. Despite the prevalence of alcohol use disorder in the hepatology clinic, few hepatologists feel adequately trained to treat alcohol use disorder. Studies have found that treating alcohol use disorder can decrease the progression of alcohol-related liver disease and lower the rates of decompensation. Alcohol use disorder can be treated with psychosocial or behavioral interventions, medication assistance, or a combination of the two. Psychosocial and behavioral interventions include mutual support groups such as Alcoholics Anonymous or Smart Recovery, and brief interventions in the clinic under the Screening, Brief Intervention, and Referral to Treatment or SBI or T model. Cognitive behavioral therapy, motivational enhancement therapy, and motivational interviewing are other forms of behavioral therapy that have been shown to be effective in treating alcohol use disorder. 3 medications, acamprosate, naltrexone, and disulfiram, have been approved by the FDA for the treatment of alcohol use disorder. Limited information is known about the use of these medications in those with underlying alcohol-related liver disease. Disulfiram is contraindicated in liver disease, but acamprosate and naltrexone have more recently been utilized in those with alcohol-related liver disease, and based on recent data, are likely safe for many patients. Acamprosate is not metabolized in the liver, but it does need to be dose adjusted for those with renal impairment. Naltrexone is metabolized by the liver and is contraindicated in those with acute hepatic dysfunction or Child's B or C cirrhosis. However, it is likely safe in selected patients with compensated cirrhosis. Other medications that have been found to be effective in the treatment of alcohol use disorder that have not been approved by the FDA include baclofen, topiramate, and gabapentin. Baclofen is the only medication that's been evaluated with a randomized placebo-controlled trial in patients with alcohol use disorder and alcohol-related liver disease, and it was found to have higher rates and longer duration of abstinence as compared to placebo. More information and resources for alcohol use disorder can be found at the NIAAA's website. On behalf of all of us on the CLD team, I hope you have found this short commentary on alcohol use disorder in patients with alcohol-associated liver disease useful. For more information about the diagnosis, testing, and management of alcohol use disorder, please visit us at www.cldlearning.com. Thank you for watching.